Knee flexion requirement: walking 70 degree, ascending stair 9 degree, descending stairs and rising from the chair 110 degree. Indication for knee replacement: pain, loss of function and deformity. Contraindication divided into two: local or general contraindication. The general contraindications are medical comorbidities and symptomatic UTI or other infections. Local problems: number 1, infection; number 2, extensor mechanism disrupted; number 3, arthrodesis, well functioning knee; number 4, hip arthrodesis; number 5, neuropathic joint; number 6, limb ischemia. X-ray: I would like to do a PA view, Rosenberg view, and 40, which is knee flex to 45 degree, beam directed 10 degree caudal, or a merchant view, sunrise view, to evaluate pedalofemoral space, tilt and alignment. Moreover, I would like to do a weight bearing X-rays. On X-ray, osteoarthritis is classified as Caligran-Lawrence classification. 0 is no X-ray changes of arthritis. 1 is doubtful, joint space narrowing or osteophytic lipping. Grade 2 is minimal, definite osteophytes and joint space narrowing. Number 3, moderate, multiple osteophytes, definite joint space narrowing and sclerosis. And grade 4, large osteophyte, marked joint space narrowing, sclerosis and deformity. Regarding the treatment, always go for conservative management. WHO analgesia leather 2010 meta-analysis compared placebo, glucosamine-glycans, codenine sulfate, and their combination do not reduce joint pain. Lose weight in morbid obesity children, obese patients versus patient BMI less than 30. Heel wedges, lateral for medial osteoarthritis. Physiotherapy, low impact aerobic exercises. Offloader brace for varus and valgus deformity if they are passively correctable and unicompartmental less than 10 degree. Intra-articular steroids reduce inflammation, increase viscosity of synovial fluid. Methylprednisolone, low solubility, longer duration of action, followed by triamcinolone. Risk of periprosthetic infection if done within 3 months of TKR. Hyaluronic 3 injections for 2 ml each over 3 weeks, or 1 injection of 6 ml. 2007 RCT shows no difference between treat with injection of steroids or Hyaluronic. NICE guidelines states thermotherapy, physical and weight loss is recommended. Topical NSAIDs and TENS are recommended. Acupuncture is not recommended. Codenine sulfate and glucosamine-glycans are not recommended. Arthroscopic lavage for knee arthritis which has mechanical symptoms provide no benefits to optimize physical and medical therapy. Technical aspects, technical goals of TKR: number 1, restore mechanical alignment; number 2, preservation of joint space, joint line; number 3, balance soft tissues; number 4, restore range of motion and Q angle; number 5, balance knee ligaments throughout the range of motion; number 6, restore joint line. Joint line is restored to prevent ligament tension and kinematics, help patellar stability, determine the distal femoral cut because every femoral implant has the same 9 mm of distal femoral offset, while the tibia has many size of polyethylene. The cut is 10 mm above the fibular head, 5 mm below lateral epicondyle, 35 mm below the medial epicondyle. Elevation leads to patella baja, increased joint reaction force, and reduce in knee flexion. Lowering joint line leads to lack of full extension and flexion instability. So elevation will reduce knee flexion, lowering will cause flexion instability. Regarding which TKR you will use, POA guidelines survivalship of 90% in at least 10 years. Ordebriton 10A plus can use Genesis or attuned knee. Regarding the knee approaches, multiple approaches. Always use the most lateral one as the blood supply comes from the medial side. Always maximum skin bridge of more than 5 cm. Medial parapetal approach is a familiar and easy approach. Between vas medialis and quadricep tendon, both are supplied by femoral nerve. Lateral parapetal approach use when the knee can dislocated patella is lateral and cannot be relocated. Mid-vastus approach does not disrupt the extensor mechanics. Less extensile approach, patella can be difficult to evert and sublux laterally instead. Subvastus approach, muscle belly of the vastus medialis lifted off the intermuscular septum. Then are the extensile approach, that is a quadricep snip approach. You go in and inside for 45-degree oblique the quad tendon. VY turn down, excellent exposure, has quads weakness later on, and tubercular osteotomy. Minimally invasive techniques and computer aided techniques are also being advised.